The first speaker this morning is Christer Sinderby. I think most of you know Christer. He invented the concept of NAVA, and he's going to talk about function and reasons for development of NAVA. Christer.
Thank you. Thanks, Art. Good morning, everyone. It's great to see that there are people who like NAVA. So, my presentation is the function of NAVA and the reasons why we use NAVA and so, or how it came about. And I'm going to try to be not too detailed because we could go into very much details here, but I think you can today find a lot of details. There's at least like a few textbooks out there today. For example, the Martin Tobin's Principles of what's it called? Practice and Principles of Mechanical Ventilation, for example, will come out this summer, have the NAVA chapter in it. There is also an encyclopedia on mechanical ventilation or something, critical care something, a European version that Jean-Louis Vincent is involved in. It's also coming out, and there's other textbooks too coming out. So I think you can find the technical aspects a lot, but the more things of why we do it and how it came about, I'm going to try to cover it like briefly here. And first, I have conflict of interest, and that is, of course, because I made some of the inventions here. Anyway, I think I would say from this point of view that my interest for NAVA and for this technology, and we don't work with NAVA anymore. Like, I mean, my lab, we're way ahead of this. I mean, we are on a whole different level today. So, I mean, this is all technology to us, but for you guys who use it in clinic, I mean, this is interesting for you. So the reasons for the development of NAVA. Well, there is like principles for mechanical ventilation I've listed here. Like, yes, we want to ensure the ventilation. We want to reduce work of breathing, protect the lungs, maintain respiratory muscle function, maintain patient ventilators synchrony, keep patients breathing, ensure patient comfort. Some of them are overlapping, but still, this is some of the targets for mechanical ventilation. So why do we then do research of this if we have these machines already? Are they working or are they not? Well, 65, this study here from Dr. Gunaratna, it's from England, I think, it's a British Journal of Medicine. He writes, however, in partial respiratory paralysis, when patient requires only assistance to spontaneous respiratory efforts, the problem of providing this assistance in synchrony with the patient's own efforts is considerable. Such patients tend to breathe against the rhythm of the respirator, increase their respiratory distress, necessitating sedation or curarization procedures, which are not always desirable. The problem was overcome by the use of a patient-triggered respirator. Does this sound familiar? So this was 65. I mean, the problem existed long before the study. So, I mean, and there's been a lot of studies about that. So we put triggers. We put the flow trigger, first the pressure trigger, we put the flow trigger, and we have flow off cycling, and we have all these things. And yes, they work, but like Laurent Brochard's group in Paris showed like quite a few years ago now, like that 1/4 of patients exhibit a high incidence of asynchrony during assisted ventilation. Okay, so the machine doesn't work. Such a high incidence is associated with prolonged duration of mechanical ventilation. The other study came from the United States. Module and DeWitt with Scott Epstein showed ineffective triggering is a common problem early in the course of mechanical ventilation, and is associated with increased morbidity, including longer mechanical ventilation duration, shorter, I don't know what VFS is, maybe someone can explain to me, longer length of stay, and lower likelihood of home discharge. This is pretty severe, isn't it? It's not cause and effect, it's associated. So now we say, of course, we have to do bigger trials and more trials. But I think still we have proven that the point is there that it doesn't work in all patients, and therefore we have to do something about it. So Martin Tobin then with Sairam Parthasarathi did a study. And they said, in conclusion, the observed errors in the indirect estimates, that is flow, pressure, and volume, of neural TI onset and duration could cause problems in patient care. So here we have it again. And what did they compare to? Well, they compared to a neural signal. So they came out with comparing to the brain signal. So then we have this guy. You see the guy here in the middle? It's a few years ago. But anyway, this is Paolo Navalesi. So we were very good friends in Montreal, and this is one of the reasons why we are here. So we started with discussions, and I will come back to how it really happened with the NAVA thing, but it was discussions. He was initiating a lot of the thoughts that our group has been working with. So then we have a Synchrony came out as a new concept. We talk about the Synchrony as a, how do you say, it's something that happens, but it's not something that is really not real. And since there is no outcome study that really showed that people die more, whatever, even though some studies were very close to do it, it's become a kind of a gray zone topic. All ventilators companies have Synchrony. Everyone says they have Synchrony. And we go and do the research, and we find that no, they don't. So looking here at what we do then is, this is a nursing paper I found just recently. It's like been out for a year or two. And they say sedation is a common solution for managing dysynchrony, but it may not always be the best answer for all types of dysynchrony. And I would say, which dysynchrony is sedation good for? I would say abnormal breathing. If the patient is not able to breathe in a way that he should breathe, maybe sedation is a good point. But I don't think that because the ventilator can't trigger with the breathing, I don't think sedation is the solution to that. On the other side, we have like DeWitt saying, asynchrony is common and deeper sedation level is a predictor of ineffective triggering. So actually when you sedate, you actually cause more asynchrony. So what one side says, this is the solution to asynchrony, while the other side says that this is actually causing more asynchrony. So how kind of weird is that? So we then go to the issue of non-invasive ventilation, where we have, for example, in the infants, what we call nasal prongs. How many in this room believe that you can actually see a signal from a nasal prong with a leak of 80–90% and trigger a ventilator and cycle off a ventilator on this? Is there anybody who believes this? Like pneumatically? I don't. So, factors affecting mechanical ventilation. I was first thinking I should take out those front pages of each paper, but you see how much papers there are, you can't do it. So, we have agreed upon daily spontaneous breathing is really important. Most studies have used, in this case, have been using like 2 hours a day of spontaneous breathing or 1 hour per day or something like that. I think probably a patient should breathe 24 hours a day. I don't see any reason why a patient should not breathe unless he is really, really severely sick and deserves to be put under. Wake up and breathe was combined in the interruptive of sedatives, and that's the same thing. Take off the sedatives 1 hour a day. Is that better than to have a good sedation protocol where you have the patient manage all 24 hours? I mean, is it treatment or storage? The Danish study that just came out this spring was like no sedation. Infants, this has not been looked upon very much. In the wake up and breathing, I could only find one study that shows that it's kind of good to let babies breathe. Villi, we know that high tidal volumes can injure your lungs, so we want to keep the volumes down. Well, volume control is nice, but it's been shown many times that you can double trigger in volume controls. Instead of 6 ml per kilogram, you get rather 10 ml per kilogram because you double trigger in many, many breaths. Ventilator-induced diaphragm dysfunction, that patients actually stop breathing when they are on the ventilator and therefore lose their muscle function, has been shown in both humans, babies and adults and animals. And is again a very kind of important thing for the weaning part. So all these factors kind of affects your patients for time on ventilation. And the thing is, how do we monitor this? Well, we monitor it by looking at this a little thing saying respiratory rate on it, and it gives you a number. And I think that Paolo is going to show you a little bit later that this number sometimes doesn't mean anything. So patient ventilator synchrony is then the other kind of factor for affecting the mechanical ventilation. And infants in this case have not been studied, but in the Cochrane database it says that the use of triggered modes is actually shortening the duration of mechanical ventilation. However, we don't know if the triggered modes are synchronized. So we talk about the negative triad: patient ventilator synchrony, excessive sedation, excessive assist, and this all leads to prolonged mechanical ventilation. So enough of that. That's the reasons why we're here. NAVA, its function. Well, NAVA, this is the first prototype of NAVA. And I think we have something else. And here is the NAVA Lazy. So in discussions we had, it's like it came out that he asked me how to trigger a ventilator, because I was doing like physiology and looked in power spectrum analysis of 100 milliseconds of EMG signals. So we combined it through Jennifer, which was actually the person who kind of did it and looked upon that this really works. So we had a team started here. This is like somewhere like in the early 90s. So diaphragm electrical activity, why do we choose that? Well, first of all, because we can measure it. And I found this, and I think this is rather interesting. This is Milik Emily, Joseph Milik Emily. He is like one of the greatest physiologists we had in the last 50 years, I think. And in fact, he says here, we started measuring the electrical activity of the diaphragm, this is 1958, by inserting a long needle through the chest wall into normal human volunteers. Not surprisingly, after a few successful attempts, we induced a pneumothorax in one of our volunteers, the son of the dean of the medical faculty of Liège. After this failure, out of necessity, we promptly developed a method to measure the electrical activity of the diaphragm via electrodes attached to a catheter, which was introduced through the esophagus and to the level of the cardia. And that's where you have the method. The method is simple in the sense you have the muscle fibers. You can see a single motor unit action potential here. You can see like the sum of them all. I'm not going to go into details on how this works. You can see here, like, see here if I go to 13 first. This is a motor neuron, so this could be your phrenic nerve. It elicits a motor, exchange of sodium and potassium along a muscle fiber. This is what you measure as electricity. Now we have millions and millions of these muscle fibers. So what we have to do is like to measure them all. We just insert a catheter down to the level of the diaphragm in the esophagus. Quite a simple procedure, I would say, because you do it with the nasogastric tubes all the time. And then once you are down there, you have the diaphragm that sends out all these electrical signals from the brain, gets converted into this, and this is where you have your signal. Now, of all signals that you have out there today, flow, volume, pressure, and so on, how many of these have actually been validated as adequate to use? Like, I mean, Martin Tobin showed that they are not valid. So what we had was, like, I was on the AITS ERS statement for respiratory muscle testing like this many years ago, but we had this thing, we had to go through, like, I don't know how many committees and how many reviews, and we reviewed and reviewed and reviewed, but in the end, like, of the electrophysiological methods to measure diaphragm electricity, the only method that was kind of left over that really is reliable is the one that we are using. So, I mean, there is a consensus on this. There is tons of science behind this. So this is not by accident that we're using this signal. So we process the signal. I'm not going to go through it, but it comes from something that looks like this, and it comes out as something that looks like this at the bottom. Now, as we grow up, you have the effect of development. Now, if a baby gets a synchronized assist, can he learn how to breathe, do you think that? It's like something that is involved here, and we have a synchrony that is severe in babies, I can tell you that. In the adult, we have stabilized our breathing, and we are much more going like clocks. What's good about having the EDI is that as you get sick, which is not good, is that to get your volume, this is a COPD patient, to get the same volumes that you have in a healthy subject, you have to increase your neural drive because work is up. So that's one of the advantages. This signal gets stronger when the other signals usually get weaker. So NAVA in itself, here you see the guy here with dark hair. That was a long time ago. And this is the prototype of NAVA. This is the one we use for nature medicine. So we have the feedback for NAVA is coming from all neural receptors. So you have like the upper airways. We're going to hear about that today. We have the lungs. We have the diaphragm, rib cage, these chemoreceptors. Even like we can voluntarily control NAVA. So if you want to take a breath, you can take a breath and you do get the assist as you wanted. The point of it is that NAVA is an artificial inspiratory muscle. You are actually assisting the patient in the way that he can assist himself. You're making him stronger technically. And how does it work? Well, I think most of you are familiar with it, but I'm just going to show you. Signal comes from the brain through the phrenic nerves gives the signal into the ventilator, and the ventilator responds. If I go to the next one here. The nice part of it is that as you actually work on the ventilator and you increase the amount of pressure you deliver for a certain electrical activity, you will see that the neural drive goes down. And if you don't get that response, start to think why. Because you should see that response. Somebody who gets assist and do not reduce the drive has other problems than actually loaded breathing. Here we can see a guy that you can find. So if you find this guy in the audience here, point at him, okay? So this is Norm. So he's actually over there. So what you see here, Norm has a catheter down here and a test lung. So first about talking about non-invasive ventilation, this is rather non-invasive. You see the diaphragm activity over here, you see the pressure waveforms up here. So if I say to him, take a deep breath, well, you get the big waveform here and you get a lot of assist here. If I say, take a small breath, well, you get small activity here and you get small assist. It's really quite neat when you look upon it. I mean, I still, like, since we did this, like the first times, like, I mean, I don't know, 15 years ago, I'm still impressed when I see it. So then well, this is actually a nice slide that Jennifer set together with Sylvia Göthberg, and it's a beautiful thing showing. This is our group over the years: catheter testing, algorithm development, validation of EDI, Synchrony evaluations, the studies on tonic EDI in babies, the non-invasive NAVA, and the Synchrony clinical studies with Survey. Here you see the FDA thing here. So from the time when we kind of got the thing out in the market, today you get a paper every 2 weeks on NAVA, because the machines are out there and people do research all over the world. So it's quite a nice development. And if we talk about the studies, this is just a sample of the studies, but synchronized assist and adequate ventilation with the mode of NAVA has been shown in adult patients, in healthy subjects, in pediatrics, in neonates, in rabbits. So, I mean, we have gone the whole loop of showing that this mode works. Still, you will hear and get faced with the question, is there a long-term study showing that people die less if they go on NAVA? Well, I think to summarize, there is evidently problems with the current conventional methods of monitoring and delivering ventilatory assist. That's number one. And two, NAVA would solve some of them. So my question is more like, why continue to work with a broken machine when you can fix it? Thank you so much.
Thanks very much, Christer. And
Overtime.
as you saw, this name was up for the whole talk. That was not Arthur Slutsky. I'm not taking any credit or lack of credit for that talk.